This is week 4 of our FOP pain management series. And today we're going to be focusing on physical therapy approaches. So I wanted to take a second to say thank you to BioChrist, who's our 2023 Family Services Programming supporter. I am going to go ahead and introduce our speaker today, and I'm so excited to welcome Dr. Julie Shulman to the FOP community officially. She is a physical therapy scientist in the Department of Physical Therapy and Occupational Therapy Services at the Boston Children's Hospital. So as a pediatric physical therapist who works with youth and young adults with chronic pain, she is excited to share her knowledge and expertise as it relates to pain science. Dr. Shulman researches how exercise and education about pain can improve the way our brains and nerves process painful information. And she will discuss how these techniques may be safely adapted to support people with FOP experiencing pain during or between flare-ups. So I'm going to go ahead and stop my share and hand it over to you, Dr. Shulman, to start your presentation.
All right. Get rid of this little box. Put this in our view here. Let's see. Can you see that okay?
Looks good.
Perfect. My name is Julie. I am a pediatric physical therapist. And Hope was just asking me, I've been in the pain management field specifically for the last 10 years, working with kids with primary diagnoses of chronic pain syndromes. So that just means that the chronic pain is the disease itself, usually without any underlying biological other known disease that's driving that. And you guys met Eden 2 weeks ago. Dr. Randall is one of my colleagues, and I was telling Hope I've worked with her for the last 10 years. So I think you're going to hear some of the same things, and hopefully in a different way. But talking about physical therapy, there's a lot of different types of physical therapy and things that physical therapists do. I'm going to really focus on like movement and motion and some other things as well that fall into that we use here to help support kids and young adults with chronic pain syndromes. I don't have any conflicts of interest to report. And this is just a slide about who I am coming into this box, to this talk to meet you guys today, what my perspective is. So I've already mentioned that I'm a physical therapist at our Pediatric Pain Rehab Center, which has just recently moved to Brookline, Massachusetts. If you're familiar with Massachusetts, this is our tiny little old clinic with our tiny gym. Back in the day where we help kids, these are all kids with chronic pain, except for our student here and our occupational therapist, and me in the back, dancing to get some exercise in. This is a bunch of my colleagues here. We really love Halloween. Where we used to work, there's a big competition every year of who sets up the best theme and costume. So we are very competitive people by heart, and we usually win, which is great. And then beyond being a clinician, I'm also a researcher when it comes to physical therapy and pain management. So I work with one of our physicians here, Dr. Sethna, and we do a lot of what's called quantitative sensory testing, where we apply painful stimuli or sensory stimuli and then ask that person about that pain or that experience directly. So we use an experimental stimulus and then understand how that stimulus felt so that we can understand how the nervous system is processing and understanding pain. And it's kind of like an outcome measure or a research tool that we can use to see are the things that we're doing helping and working. And then recently we've gotten into a lot of virtual reality space. So working on some grants to develop virtual tools that allow physical therapists to actually jump into virtual sessions with patients to be able to treat them in a fun virtual environment, which is obviously great for kids. And then me, I'm a boxer mom by heart, on my second boxer Burton right here. So very, very active if you've ever had a boxer. And then also I love to ski. I love winter, which is why I live in Massachusetts. So can't wait for the seasons to start changing and see some beautiful snow. If I can get this to advance. There we go. So just a disclaimer that I am new to FOP. I haven't necessarily worked directly with patients with FOP. So I would love if there's something I've said that doesn't quite make sense for you, or if you want me to explain something or have questions, like please feel free to engage me in that conversation throughout. This is a picture of a walker in the middle of winter in 2015 in Boston, where we had our record snowfall. It snowed every Monday and Thursday, 2 to 3 feet for 3 weeks straight. And we have public parking in front of our homes. And so we use space savers to save our spot when we go to work, that you shoveled out all of that snow. And this was my favorite space saver from 2015, a nice rolling walker. So great tool, useless in that environment. So if I'm giving you tools that if you feel like in the environment or who you are not helpful, please feel free to give me that feedback and we can rethink how it might be helpful for you. So I just wanted to know from you guys, if there's anything in particular you wanted me to talk about today, if there were any expectations that you had or questions you had in advance, of points that I might be able to hit or think through more. And if you don't have any, that's okay too.
One thing that I wanted to ask came in from a mom who's not here, but hopefully she'll be able to watch the recording, is about for parents, and because you work specifically in the pediatric community, what are some ways that maybe as a physical therapist, you're able to pick up on a child's pain if they're not one of those children who feels comfortable telling mom or dad that I'm in pain? So like if there's any specific signs that you notice about revealing pain for kids who aren't as verbal about it.
That's a great question. Will you, I don't talk about that specifically, but will you remind me at the end, Hope?
Yes, I will.
Tie that in. Any other specific questions? I lost my chat, so let me just double check. Okay. Well, feel free, like I said, to interrupt me as I go along if you have a question about something, unmute or write it in the chat, whatever you're more comfortable with. There we go. What I'm going to talk a little bit about is I'm just going to glaze over how we understand, well, first of all, the treatment model that Eden already reviewed that I work in. So this will be kind of a reminder refresher that we use here. And then I'm going to talk a little bit about what pain is and how we understand it as physical therapists. And then some of the tools and techniques that we use, including a lot that we borrow from our psychology colleagues and integrate into physical therapy practice. And then hopefully give you a couple resources that might be helpful as well. So if I say the word PPRC, I've probably already said it. It's Pediatric Pain Rehabilitation Center. It's too long to say, so we just call it PPRC. It's what we call a specialized IIPT, to give you another abbreviation, which is just a fancy word for a program where you have a bunch of different disciplines working together towards a common goal with the patient at the center of the treatment. And usually here our focus is on helping somebody get back into functioning, get back into life, even though the pain is present. So teaching them how to not let pain limit or be the boss of their lives, and trying to find unique ways with our own discipline hats of how we can help support them in that journey towards health and wellness. So we really use that biopsychosocial model that I know you heard all about a couple of weeks ago. The disciplines we have, really medical disciplines, so physicians, nursing, physical therapists. OT is occupational therapy, which I know doesn't exist in every country. So that can be a little unique. And then psychology, psychiatry. We also have a music therapist, recreational therapist, and probably someone else I'm forgetting about as well, social work. We take about 8 patients at a time between the ages of 8 to 18. Hope alluded to the fact that we just opened a young adult model in the afternoons where we now take patients up to the age of 26, but we keep those 18 to 26-year-olds separate from the pediatric patients because they have different concerns and different issues that they're working on. And then usually kids are here Monday through Friday, the whole day, longer than a school day, for 3 to 6 weeks. There we go. And just here's an example of our schedule where they really do a lot of physical therapy, occupational therapy, psychology in the morning. And then we have some group treatments as well. And importantly, we integrate the family into the treatment. Let's see if as well as we really focus on integration back into school, because school is the work of childhood. In these programs, or when we're talking about chronic pain in adults, we're obviously often talking about return to work or participation in work and those sorts of activities. And HEP means home exercise program. So our patients get a lot of exercise. They do 2 to 3 hours of physical therapy a day, and then they go home and do another 30 to 45 minutes of exercise as well. Eden talked to you guys about the biopsychosocial model. I don't know if you've ever seen the ICF model, or their International Classification of Functioning and Disability. This is the child and youth version, but it's actually the same, and the adult version is the same. And this is just the framework and how physical therapists think about and understand disease within the, like, it's kind of a broken down biopsychosocial model. So we have the disease or the health condition that's presented in front of us. So chronic pain syndromes or FOP. And then we try to get an understanding of what biologically is happening in the body in terms of like your muscle strength, your range of motion, your ability to move, how well your body functions are working or not working. And then we think of activities that impacts. So, you know, if you can't straighten your leg or you can't bend your knee enough, you might have difficulty sitting or standing or getting in and out of a chair or walking. And then really the other thing that we think about is participation, which is really the most important thing, which that just means like you actually doing the things that are meaningful to you in your lives. So being able to work and function successfully in your job or family or social circles, to be able to feel like you're participating in those things. And then, of course, understanding that these psychosocial factors always influence what we're capable of participating in. Our thoughts and beliefs about what we're capable of doing impact what we're willing to try or what we're willing to do, just as much as our range of motion, right? Or our ability to do something also impacts that as well. This is a slide I stole from Eden. So obviously as physical therapists, our end goal is always participation. So it doesn't mean anything if you can go like this with your leg 10 times. It's meaningful to you and to us if because you can do that activity, you can now sit in a chair and work for a certain number of hours or be able to get in and out of the bathtub or do something that really helps you participate in your life. So of course, we want to understand how pain and function is limiting your ability to live your life. And the more that we can help you be able to participate while respecting any limitations, it leads to greater happiness. And that can, as Eden said, indirectly influence the pain experience. So this is the dry part. So how pain works, which you may have heard this before, and this is very oversimplified, is most people actually think of pain as a one-way street, right? Like this is from Descartes, from forever ago, who wrote like, you know, here's how our nervous system works. You feel something that should be harmful or dangerous, like a fire, maybe a spike, like, or something like that touching you, a Lego that you've stepped on that got left out. And it sends a signal all the way up to your brain. And it says, ouch, like that hurts. Please do something about it. Please take your foot out away from the fire, your body away from the fire so that you don't end up getting harmed. But there's also factors that go the opposite direction. So the brain senses and feels pain, but it can also turn pain down or turn pain off. So you can think of the people who are capable of walking across hot coals, or you've heard the story of the people who have had a traumatic event, like got bitten by a shark or something, or maybe you've had a traumatic event and you didn't feel anything in that moment. You feel it much later on because your body has kicked into survival mode and it's able to dampen the pain so that you can function and do the things you need to do to become safe. But essentially, with those two kind of ways going together, what we're really sensing when we sense this fire or anything else is danger. So if our brain detects something as dangerous, it will tell you that it's painful and you will have a painful experience. So it's always a danger message. You can have pain without the fire, without something harmful being there. You can also have pain with the fire, or you could have the fire and you could actually not feel pain if you weren't interpreting that situation as dangerous. So when our danger messages in our body or our brain outweigh any messages of feeling safe or protected or okay, that's when you're going to generate that painful response and that pain experience. So it's complicated. And this is another term that we use, central sensitization, for chronic pain, that when that's become out of whack and we're sending messages to the brain too easily to generate pain when maybe there's nothing there. And also maybe our brain isn't as good as turning that pain signal off, and that becomes out of balance. We call that central sensitization. So these are just also the ground rules about pain. We talk about pain a lot as coming from the brain. And then sometimes people think, oh, and we have a psychologist involved, like, oh, you think my pain's all in my head. Well, it's technically in your head because your brain is in your head. But it's not, it's always real. So pain is always real. The experience that someone's having is always very valid and real. And it's unique to every individual because it comes from the brain and it comes from your past experiences and what you're expected to think of it based on that. And then the other important thing to think about is that pain doesn't mean that you're injured. So that's an important lesson that we're teaching individuals with chronic pain is just because you're having pain, you have to assess the rest of the situation, right? The instant response might be danger, but when you stop and think about it, it might be actually, I have all these other safe factors going on, and I know that this is safe, and this pain is coming from maybe that sensitization piece, and I'm actually safe and I'm not injured and it's okay to move. And that's what helps that pain turn down. You have, I hope you've been asked how much, at least in the United States, this is big. I don't know if it's as big in other countries, but we have to ask about pain every single medical visit, which we actually don't. We break that rule here intentionally. We don't ask people about their pain a lot because it brings attention to pain, which makes pain worse. But you've probably been asked on some sort of rating scale from 0 to 10, how much pain are you in today? And what we're hoping to measure when we ask that to you is like, do you have an injury going on and how bad is it? But what we're actually measuring when I ask somebody about their pain is like so many different things, that biopsychosocial picture, right? Like your attitudes, your belief, how much pain you're actually in, what's going on in your nervous system. Also the environment that you're in, the day that you had, the mood that you're in is all going to influence what you're reporting in terms of pain. If I have a really bad day and I spill my coffee all over me on the train, and then I get to work and I stub my toe, I'm probably going to have a higher pain response than if I just kicked the winning soccer goal and had the same thing happen. So it's all contextual and based on what's going on in our world. So a lot of times when we are working with patients that we know are having chronic pain or pain that isn't necessarily dangerous, we like to rephrase our pain assessment, since I don't want to ask from 0 to 10 all the time. It's not even about pain, but just like, is what we just did, the activity that we did, how difficult was that for you? Or how challenging was that for you? Was it easy, medium, or hard? Because so many things can go into making something feel easy, medium, or hard beyond pain itself. So if it's maybe easy, then great, let's keep going and do more. What we're really looking for most of the time is that just right challenge for yourself or for your body, so that it's a little bit challenging. We're helping the body shift and get better and stronger, but we're not pushing it so hard that we're going to end up having a setback. And then if something is hard, that says to me, maybe the activity we're doing was too challenging and we should walk it back a notch or stop and change activities. Have you guys talked about acute and chronic pain and the differences between acute and chronic pain?
We have touched on it a little bit, but we haven't dived deeply into it.
Yeah, this isn't from my experience. So acute pain is pain that actually is coming from something biologically in your body that is dangerous potentially. So has the potential to harm you, right? So as a person with FOP, that's that pain that might be an indication of a flare-up happening, right? And there might be a need to protect, right? In response to that, to protect your body, to protect that body part. And that's what you should do. Just like if I broke my ankle, I might end up in a cast and on crutches, and I'm having a lot of pain, and that pain is telling me to protect. So that's a healthy pain system. It's saying, protect your body, right? There's tissue damage or potential for tissue damage. So it can be those signs of the disease process. You could have other signs and symptoms that go along that of inflammation, like maybe swelling, redness, hot, heat to the body part. And that tells us, well, we need to be careful about what we do, and we need to protect at least this area of the body to make sure that you don't cause any harm. On the chronic pain side, so when pain is not protective, you can get these pain symptoms in between flare-ups, right? And I think you've talked about that, and a lot of you must experience that. And that's non-protective pain. It's not dangerous. That's that nervous system imbalance out of whack, sending that pain message saying like, hey, protect, you're in danger, but maybe there is nothing dangerous going on at that time. So there's no signs of the disease process. And most people who have these types of disorders, where you have pain in between biological acute flare-ups, tell us that it feels different. And they usually can't verbalize to us what it is, but they know when it's chronic pain. And when it's maybe something that's more of a flare-up. And so often that's a helpful cue, like, okay, like this is different. There could be some differences in the biological signs of swelling or redness or things like that as well. And essentially the main difference in the approach is that often there are some things that you may be able to do in a chronic phase that you may not be able to do in an acute phase. So it may be, healthier if with chronic pain or to exercise, to continue to use that body part to send the message that everything is okay. But if it is acutely flaring, obviously you want to go to those protective responses and activities. So really with chronic pain, we want to avoid relying on any passive strategies for coping. And I'll talk about what those are in a second. Just check the chat. Perfect. Okay. Any questions so far? So this is just like what I talked about too. Like obviously you can have an acute flare of pain and then pain in between episodes. That's what we call our non-protective or chronic pain. And then you can obviously have acute flare again and go through these phases. There are several other conditions that tend to follow this pattern where the chronic pain is the secondary diagnosis to the primary disease, like sickle cell. We'll see people with migraines with chronic headaches in between their migrainous episodes, and some rheumatic diseases like rheumatoid arthritis, ulcerative colitis, but those underlying biological issues that are maybe under control between flare-ups, and they're still getting those episodes of pain. Keep losing my mouse. There it is. So I had mentioned that passive coping is less helpful when the pain is non-protective or when the pain is chronic, so that between flare-up pain. So passive coping can be very helpful. I use it. I think we all use it sometimes to relax, like taking a bath or getting a heating pad or an ice pack. There may be medications that you take for pain and things like that. And those can be really effective when there's a biological process going on. So if you're having an acute episode of pain, yes, taking pain medication, putting ice on the body part or a heating pad or whatever you prefer to do, and resting and protecting can be helpful. But usually, even if the pain is acute, we tell people to pair this with something that's more active and engaging, mostly because it engages your brain and distracts you from pain, but also it gives you a better sense of control. It can give you an extra sense of this is what I can do about this for myself. That's you actively, working to support yourself through that difficult moment. And either way, well, I guess neither active or passive coping are really intended to take the pain away when we're talking about chronic pain. Obviously, pain medicine should help with your pain if it's an acute episode. But when we talk about coping, it's not all about taking pain away. It's often about helping you get through the experience by putting the pain or the discomfort in the background and helping the focus of your attention to be something else. So Eden gave you guys this like example of a great, huge coping list from one of our patients here. I work with kids, but honestly, I've worked with adults too. The number one thing to get through something hard is distraction. Focusing on something else that you really enjoy that is also really engaging so that you can, pain is an attention grabber. So you have to find something attention grabbing enough to override that pain signal that wants to come to the forefront of your brain. So we, tell patients to find their favorite things and try and do those, whether it's playing a game on your phone, playing a game with someone else, playing a really fast-paced game. If you can get through that, whether it's a word game or a card game or a game on your phone, like can't remember the name of it, like Frogger, where you have to run across the road and not get hit by the car, but something that really forces you to pay attention to it. There's also different, moving your body, I'll talk about in a minute, can also help support pain reduction and helping get back on track over time. A bunch of relaxation strategies, aromatherapy, I heard you guys talked about, would be one of those strategies, music, anything that helps your body feel relaxed and calm. And then I know Eden talked a lot about thinking strategies. And the whole point around the thinking strategies is it provides you with that sense of safety, like thinking about what's going on and how, if it's chronic pain, your body is safe. This activity is not going to harm you. This is going to help me get better. This is going to help me get stronger, to help kind of override that message of danger. And everybody uses coping. I don't know a single gym I've ever been to where they didn't have a TV on the treadmill. That's for a reason, because nobody likes being on a treadmill. And if you do, maybe you're a strange kind of person or unique individual. But it's because the TV helps distract your brain from the difficulty of the running activity. So just like coping and pain, right? Like the coping helps you get through that difficult moment. So you still have to run on the treadmill. You still have to run a mile or do whatever your workout is. But the fact that you're watching TV and coping with that and not focusing on how hard the run is, in a sense, makes the run easier than just sitting there and looking at the time and asking yourself how much time I have left. So finding those activities that help you enjoy yourself more and help you get through that difficult moment can be really useful. So this is like alluding to what I just talked about, is how does coping work? If it's not taking my pain away, how does it work? And I work with kids. So my favorite analogy is mother nagging you. So everyone has probably had some sort of caregiver or mother nag them to do something, like probably adults as well. I get nagged as well. So, but the teenage kid who's in the room playing video games and they're like chatting with their best friend, having a sleepover. And I tell them, well, your mom has been screaming at you for the last 10 minutes to come upstairs because dinner is ready. And she comes downstairs and she's like, I have been screaming at you for the last 10 minutes. Like, why haven't you come upstairs for dinner? And what's their response? I didn't hear you. Like, because they were so engaged in that really fun thing that they were doing, they actually couldn't hear their mom screaming at them. Their mom was screaming at them legitimately. It was an audible, producible noise, but the brain didn't process that information and bring it to their attention because they were so attention focused on something else. And that's the same with pain. So pain is the nagging mom. If we can help them shift their attention onto something else, you can't hear the nag. It's still there. It's still in the brain. It's still being processed, but it helps shift that attention off. And then you actually don't even perceive it. So thankfully, our brains are not good at multitasking, and they're only good at focusing on one thing at a time. So if we can make that thing not pain, it can really help you have a better experience. So yeah, it might be the opposite with adults, where maybe the kids, you're trying to tune out the children nagging you on the other side, but that's my favorite analogy. So next I'm going to shift a little bit into how physical therapy, like some of the techniques that we have in our own field, help with chronic pain syndrome specifically, and then how that might apply to FOP. But one of the big things we're trying to do is reverse the cycle of disability and pain and deconditioning. So you may have talked about, right, like we think of it as a cycle of you have pain, and then it's because I have pain in this body part, I stop moving it all together, and then I stop moving it all, and then I end up deconditioned, and now I have to kind of recondition my body to get out of that. So we use a lot of exercise and movement to help with that. And then, of course, we're big in the biopsychosocial model. So understanding the triggers and developing strategies to help individuals participate in the things that they value and enjoy or need to do. And as physical therapists, we either take a habilitative or a rehabilitative approach. And that's just the difference of rehabilitative means we're going to restore functioning to typical functioning. We're trying to get somebody to look like a typical individual of their age. But sometimes with some disorders or diseases like FOP, we might have to take into consideration how to accommodate. So because you might not be able to do it in the typical way, how can we support you in accommodating that activity so that you can still enjoy it and access it, but maybe in a slightly different way? And then here we do a lot of helping implement the coping strategies that psychology is teaching or has been teaching into real life, or into the activities that are actually hard or challenging because of pain. So sometimes I call it in vivo psychology. So you're practicing the skills from the psychology office in real life situations and activities. So this is my joke here. We use a ton of exercise and physical therapy here, a lot of movement itself to help restore a healthy nervous system as well as a healthy body. Obviously, it's hard to take, right? So you can't just be like, here you go, here's this pill. But movement actually is medicine. So we consider exercise, moving the body, to be a pill that someone takes, the same thing that someone takes to improve their pain and improve their functioning. And a lot of times with chronic pain, actual pills don't work for reducing pain, but movement itself and exercise has a big effect on the body and all of the systems in the body. So your cognition and your brain, your gut and your GI system, your, muscles, obviously, and bones and joints, your immune system, all sorts of systems. So moving and exercising, actually, even though it's hard and takes longer than swallowing a pill, has a really big effect on the body physiology. So it's really important to stay active and moving for multiple reasons, however you can. So these are just some of the benefits that we know about movement in general and for pain, is that exercise activates our endogenous opioid system. So that we call it like a runner's high. When you exercise and it goes well, you feel good. Your body releases these natural opioids and chemicals that actually help reduce your perception of pain. In the US, we use the CDC, or the Center for Disease Control. And for kids, we recommend an hour a day of exercise, usually through play or something fun. I would argue that adults should be playing something fun as well when they exercise. It makes it way easier to do. But for adults, it's a little bit different. We recommend 150 minutes per week of some sort of cardio aerobic activity, like running or walking or biking or swimming, and then some sort of muscle strengthening program 2 days a week. And that looks different for everybody. The interesting thing about this, at least in the US, is we don't modify this for people with disabilities or disorders or diseases. It might look a little bit different, but the recommendation of exercising stays the same. The other benefit of movement itself is that it can block the transmission of pain signals in your periphery, like outer body, or in your body parts. So the way that this works is that descending modulation system of pain that can turn pain down or off. But if you have ever had a hammer or something and you jammed your finger or you slammed something on your finger, the first thing you do is this, shake it out, right? And the reason for that is because that input of the movement and the sensation from the body actually sends a signal back up to your brain that it's moving, and it turns the pain signal down. So it's actually pain relief directly. So when you're moving something that's in pain, it can help block that signal coming back down to the body. And then movement is great. It helps us, it can help prevent contracture. So we consider that to be like a joint getting stuck in a certain position, right? So active movement or things like that can help maintain range of motion, even during a flare. So, not like pushing against it or trying to push against it, but moving that body part gently through that range of motion can help preserve the range of motion that's there. So this was my thought and my take and my best interpretation of understanding other chronic diseases that work a little bit like FOP and what our guidelines are as physical therapists for those types of conditions, because there are no physical therapy guidelines for FOP, which when I was talking to somebody, an individual with FOP, they were like, PTs are afraid of me. I'm like, well, yeah, there's like nothing, there's almost nothing out there to say like, what's safe and what's okay. And we don't really know. So it's a great opportunity, I would say, for us to start learning more about it and how we can support your community. But inferring from some other diseases where exercise-based trauma can lead to disease progression, these are some of the recommendations that we have. So I don't know if you've ever heard of muscular dystrophy. In pediatrics, we see a lot of individuals, boys with muscular dystrophy, where exercise and overloading muscles specifically can lead to breakdown of the muscles and further decline in function. So we have to be really careful with making sure that we are not making the muscles any worse, that we're not helping make the disease progress faster. And so our recommendations for populations like those are usually to move, like movement, the more the better, but it should be low intensity, so not hard, and low impact, which means like not, pounding activities like running and jumping and things like that. So movement is still important during acute and chronic pain episodes. It's just a matter of making sure you're dosing it right. And aquatic therapy or just being in a pool of water is another great way to go low impact. It's not the only way. Some people don't like pools, and that's okay. Biking, swimming, walking would all be examples of low impact. Yoga, things like that. And then the biggest thing that we tell people is to listen to your own body. So everybody is so different in terms of what you're going to be able to tolerate and do. And so the important thing is to listen to what your body during the activity, and then also importantly after. If you do a bunch of stuff one day and then the next day you're like extra sore, extra tired, it probably means that you did too much too fast. So just listening and staying in tune and understanding, oh, that I did yesterday, maybe the next time, like I go out and go for a walk, instead of going for an hour, I'll try a half hour and see how that goes. And your limit may change over time. It may get better, and that's great. But if it's new to you too, we'll talk about pacing in a second, making sure you're starting at a place that it doesn't feel too hard or too challenging. And then if you're feeling like you have some goals that you want to set for yourself to improve some aspect of your functioning or being able to participate in the things you like, I would recommend working with a physical therapist. Psychology does a little bit of this too, to develop some goals. We call them SMART goals, like just to make sure that they're measurable and time-based and reasonable and achievable, all those, and specific. But setting up some goals of what it is that you want to work on if you feel like you need support, and being able to think through how to get there. And then, of course, using those coping strategies as you need them while you're doing the activity, especially if it's really hard or really worrisome, like adding in some distraction or relaxation activities to make sure that you are getting through the experience in a way that feels pleasant and not just pushing through it and then being like, that was awful. Because that's not a good experience either. So Hope pointed out that you guys are going to work through a pacing and the workbook activities that you have. So I talk about it just a little here. This is one of the stickiest points with the patients and families that we work with. It's really hard to understand pacing. So this graphic is just kind of describing on this axis here, your activity level. And then this is just time. So days or hours during the day or whatever. But basically what happens to some people over time, especially with the patients that we see, is they'll start to experience pain with an activity. And so they'll protect themselves. They'll either protect themselves and slowly reduce the number of activities they're doing to avoid a pain flare and end up really not having much of an activity level down here. Or, and these are two different personality types, I think. I'm the second one. You'll have a flare in your pain. So you just rest for a little bit, a day or two, just lay down and do nothing. And then something exciting comes up on your calendar and you're like, okay, I'm going to push through that. And I'm going to push through that, not cope. I'm just going to do it. And then you end up busting again. And so you kind of go through this boom bust cycle, and eventually you can't do as much either. Because you've been resting in the middle, and both people end up not being able to do as much activity. So it's important, if exercise or movement is something that's new to you, to making sure that you're starting at at the threshold of that intensity that feels just right. So you're not going beyond this line here, right? That you're kind of maintaining so that you can maintain your function and activity level before kind of hitting that pain bust out point more constantly and consistently, that your activity level is hopefully actually moving in the other direction, your activity tolerance. And then some of the other techniques of pacing are just energy conservation or activity balancing, thinking about your day, your week, whatever it is, and thinking through it ahead of time and thinking through, do I have activities that are refueling to me, that are restful, and energy consuming activities, like maybe going grocery shopping or whatever it might be, versus sitting down and reading a book or watching a movie with your family, and making sure you have both of those things in your schedule and that they're balanced. Like me, I like to go to the gym first thing in the morning and then do everything I need, clean my house and vacuum so that it's all done. And then I can lay on the couch for 4 hours, but that's not ideal. Ideally, I'd be mixing in going to the gym, coming home, relaxing, reading my book. Okay, now I'll go vacuum. Okay, now I'm going to go read my book. And then now I'll go to the grocery store. And now, so if you're really struggling to maintain that activity level and crashing, making sure you're balancing the day with periods of rest and activity. And then some people have times of day when they're at their best. So putting those activities that are going to be the most challenging when you have the most energy, scheduling them into that part of the day, if that's a possibility. And then just remember, if you do bust, it's that sign, right, that your activity was too high. So it doesn't mean you did anything wrong. It just means start smaller, start slower and start smaller, and you'll hopefully get yourself able to do more over time. This is another aspect of the treatment that we do for pain. I actually don't know if people with FOP struggle with this piece of chronic pain, where you can have changes in how your sensory nerves work, where things that shouldn't be painful become painful, or things that are painful become a lot more painful. So sometimes that can lead to difficulty wearing clothing. For some patients, it's actually difficulty with other sensory stimuli like sounds, lights, things like that, where our body has really had a heightened sense and doesn't tolerate those things as well. And so our occupational therapists are really great at this. Physical therapists also can do desensitization as well. But it's starting small and retraining our nervous system to tolerate that stimulus. And then that stimulus is safe and okay. And we don't need to worry or protect in response to it, obviously using a lot of coping strategies. So we're just like exercise pacing, we're trying to reset the threshold, right? So that the pain alarm bell doesn't go off so early or so soon, and you can tolerate more. I put on here, we actually don't use this with our patients here that have primary chronic pain. So don't tell them I'm talking about this, but has anybody used TENS, transcutaneous electrical nerve stimulation? You may have, you may not have. It's essentially using that same theory where I told you that you shake your hand when you hit it with something, you shake it out. It's using the gate control theory of pain that are like essentially another sensory stimulus will block pain. There's the gate closes. So if another stimulus is going up to the brain, pain can't be felt as strongly. And so what we do is you take these little electrodes and you put them on your skin where the site of the pain is. It's usually where the site of the pain is. And you turn it on and it feels like when your foot falls asleep or when your hand falls asleep, like a little buzzing electrical sensation. And that sensation blocks pain. So while it's on, it's really helpful in reducing pain. I think, and personally, it's a little probably better at reducing acute pain. So maybe more like flare-up pain than it's going to be at reducing chronic pain, which is more complicated in how the nerves are working. But you can buy these, at least in the US, like on Amazon. This is the one this is the unit in the US that we recommend, but there's lots of brands and lots of types and things like that. And it's not muscle contraction. That I think that for FOP, I would tell people if your muscles are twitching, it's too high, because we don't want to like activate those muscles too much over and over. It would be like exercising it over and over. But more of like just that sensory stimulus that you're just feeling that buzz, but your muscles aren't going twitch, 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 because it can move your muscles as well. So that could be a helpful thing to explore if you haven't looked into that already.
I had a question about
Yeah.
the TENS unit. Is that something that people can use then sort of throughout the day, multiple times? Is it something more that you would limit use necessarily on?
There's no reason to limit use other than if your skin is really sensitive, because you put on these little sticky patches. So, I mean, you would take them off like in between uses, but some people will use them if there's a painful activity that you have to do, or if you're having a lot of pain to help you get going. Usually I would tell someone to leave it on for like 10 to 30 minutes at the most. Your body has this ability to accommodate to stimulus, right? So when you put on something uncomfortable, women understand this, like pantyhose or a tight skirt, it feels really uncomfortable when you first put it on. And then 20 minutes later, it's not uncomfortable anymore because your brain has accommodated to that stimulus. So just like that with the TENS, your brain will forget it's there and then it doesn't work as well. But yeah, you can use it multiple times a day. There's no real, I would say if your muscles are twitching, you need to be careful because that's muscle exercise. But as long as it's just that buzz, having it on is fine, but I wouldn't go more than like 30 minutes at a time.
Great. That's very helpful. Thanks.
Yeah. And then the other thing that you guys are doing already with your workbooks is educating yourselves on how pain works. Can be really reassuring and turning that danger signal off, right? I talked in the beginning how the only thing pain is, it sounds like oversimplification, is an alert to something that's dangerous or potentially dangerous. So if you can reframe your thoughts on that pain not being dangerous and kind of take that control back and send yourself safety messages and understand pain itself and how pain works, and that it doesn't always mean that there's something dangerous happening, that turns pain down itself. So there's resources for kids now, which is great. That's a little bit newer. The adult pain world was actually further in this pain education. So I think you guys must have already heard about Tame the Beast and your workbook. And then Josh Pate has done a lot of stuff He was a PhD student of Dr. Mosley, who's pictured here, who did a lot of adaptation of that work to kid-friendly language. And then I did share a resource with Hope called Lorimer Mosley has done some work, and he has a handbook called Protectometer that has some activities you can do in it if you really want to understand a ton about it. He also has more books that can be very sciencey, called Explain Pain, and then Explain Pain Supercharged, which is just the second edition. He's Australian, and he's very funny and humorous. He has a ton of videos on YouTube. I just tell people to prepare yourself for a lot of sarcasm and adult humor if you're using his stuff as a resource. So if that's your thing, he's very entertaining. Let's see. And then I just put in here, like, on goal setting, if there's something that you're having trouble doing that you want to be able to work on, oftentimes you can do this on your own. But if you feel like you need extra support, you could reach out to a mental health professional or a physical therapist, depending on what that goal is, and who would be the best person to work on that. But, when I write goals with patients who are having pain, like, just focus on the thing you want to be able to do. Don't worry about whether or not you have pain while you're doing it. It's about your ability to do it and feel good about it. It could be, if you're having sensitivity, it could be wearing clothing. It could be doing anything of your usual activities. Like, I want to be able to brush my hair, or I want to be able to wear this type of clothing, or get dressed, or drive, or whatever it might be. It could be, I want to have better endurance so that I can go for a walk for 20 minutes every day, or have more independence in your mobility with something. So I think it could be helpful to just think through, what do I want to do? Set that goal. And then sometimes if you can't figure it out on your own, work with someone to help you figure out what those baby steps are to be able to get to that point. And I think too, in terms of danger and safety of pain, working with a clinician can send a really strong safety message if you really trust that clinician. So finding providers that you trust and working with them, they're going to be monitoring you and making sure that your body is safe and you're not doing too much. And I think that could be really valuable when you're just trying to get started and you're not sure if you're doing it right.